Dr. Nadya Youssef, who is Senior Consultant Neonatologist and Deputy Head of the NICU at Paris Haday Hospital. And we are waiting for this topic titled Neonatal Pain Management. Should we be concerned? دكتور نادية احنا تعبناكي قوي امبارح والنهارده بس احنا مستمتعين جدا ان شاء الله.
شكرا جزيلا. طبعا صعب قوي ان انا اتكلم بعد الدكتوره معتزه، يعني بريشر عالي شويه. التوبيك فعلا هو عن pain، يعني should we be concerned. Okay. No disclosures for this talk. Yani we work in the neonatal intensive care. Our patients are exposed to a multitude of procedures every single day. And we know it's challenging to detect and to measure pain in the newborn. They can't communicate very well. We have to look at their behavior. Unfortunately, pain and discomfort are common in the NICU. And the study of pain in neonates is relatively new and still evolving. There's a large gap in knowledge related both to pain assessment and to pain management. And the history is really not very glorious. Morphine was invented or extracted in 1806. But up until the 80s, infants were undergoing surgery without analgesia. The Liverpool method consisted of paralyzing the infant who underwent PDA closure without anesthetics. We were very scared at that point about the adverse effects of anesthetics, and we thought that infants were too immature to feel any pain. However, this has been proven to be wrong. Already in 1985, we learned that there are severe adverse physiological effects of this Liverpool methods. And when we use anesthesia, we improve outcomes. And this is when it started to take off. Since then, we have had a number of statements about how we should be using anesthesia for newborns, both operatively and post-operatively, and how we should, as a patient, right, be assessing neonatal pain as with any other age, both for anesthesia and surgery, but also for procedural pain, assessment and relief. Of course, we have some issues related to what the drugs we're giving might be doing to the babies. But we know more and more that human infants will show cortical activation following painful stimuli, even if they don't necessarily show any behavioral responses. We now have more than 40 different infant pain scales. مش عارفة ده يمكن أحسن. مش عارفة. اشتغل؟ تمام. ما بعرفش ألبس. The AAP issued the statement in 2015 on the prevention of pain in neonates. It should be our goal as pediatricians and healthcare professionals, not only because it's ethical, but also because we know that repeated exposure to pain has the potential of serious adverse effects. And you can see what's highlighted. We need to have, as our institution, a pain prevention program that includes strategies on how we can decrease the number of painful procedures. And we need to have a plan about how we will assess and manage pain routinely and what we're going to do to treat it, prevent it and treat it, either for minor procedures or for major procedures and surgery. But unfortunately, I think we still have a number of misconceptions about neonatal pain. We might believe that the pain pathways are too immature to transmit all the painful stimuli to the brain, or that we need to have a fully developed brain to allow for pain perception, or perhaps that the newborn is not psychologically capable of identifying uncomfortable experiences as pain. And there's also the fact that we think that the newborn is at higher risk of adverse events for pain medication and sedatives with long-term effects on brain development and behavior. And there are many questions about that. But most of these are myths. What do we really know today? We know that preterm and term infants can and do experience pain and stress responses to noxious stimuli. We know that starting the second trimester, we have a fully functional sensory system for pain. We know that the fetus has a nervous system that will transmit pain, touch, and vibration via different pathways. And we know through neuroimaging and neurophysiological studies that the newborn brain does respond to painful stimuli. And we know also, sorry about that, that not only can the newborn experience pain, but the newborn is more sensitive to pain than older children and adults, and also more susceptible to long-term effects of painful stimulation. We know that adequate treatment of pain will decrease clinical complications and mortality. And the fact that the baby is not necessarily showing changed behavior doesn't mean it's not experiencing pain. The thing is that we have an unbalance between the different excitatory and inhibitory systems, and the reflex pathways are diffused and poorly tuned, which makes them really at high risk for other complications later on in life. If we look at the newborn and the newborn pain system, first of all, when it comes to the peripheral nerves, they're vulnerable. They're very sensitive to tissue injury. And then we have the dorsal horn sensory pathways. They're immature and they will undergo major reorganization. The nociceptics or pain reflex pathways, they're diffused, they're poorly tuned. And what happens is that we'll start off by having primary hyperalgesia, which will develop, and later on, it can lead to secondary hyperalgesia. We've got unbalanced descending controls via the brainstem, and then finally, we've got the cortex. We know that extensive cortical development begins postnatally. There's a lot we don't know about what happens in infancy. And then again, we know that we have the somatosensory cortex that is activated by painful stimulation early on, but what about the other cortical regions? We don't know much. The pain responses we will see are multiple. They could be from the autonomic nervous system. We see changes in heart rate, breathing, blood pressure. Hormonal, we've got release of cortisol, catecholamines, and stress hormones. And what we can see on the naked eye are behavioral responses. And what we do now, what is really, really important, is that we can really either reduce or prevent a number of these responses if we take care of the environment. If we take care of the environment, if we include the family, if we also think about reducing the way we're doing the procedures, and think about how we can use to the best pharmacological and non-pharmacological interventions to prevent, reduce, or maybe eliminate pain in many clinical situations. The consequences of pain are quite numerous. We have the immediate ones we can see: fear, increased oxygen consumption, and so forth. We've got the short-term effect and long-term effects, because unfortunately, we're afraid of anesthetics, we're afraid of analgesics, but pain in itself, when it is not treated, will change brain development with really adverse effect related to development later on in life. Repetitive stimulation, painful stimulation in early life can lead to increased pain sensitivity or chronic pain syndromes. We don't know much about infant chronic pain syndromes. But when it comes to the neurodevelopmental impairment, this is something that has been shown. The frequency of exposure to pain-related and stress-related incidents leads to an impairment in cognitive development. It needs to alter neurocognitive processing. And we can actually see the changes on brain when we look at the brain. The neonatal brain changes with a decreased total brain volume. This is early changes, decreased white matter, and decreased basal ganglia volume and metabolism. And this is especially in the most vulnerable infants. So extremely preterm infants on their own are at high risk of neurodevelopment, of adverse neurological outcomes. When we add pain and repeated pain, this increases adverse effects. And this has been shown also in the long terms. School-age children, when they are scanned, you can see that there is decreased cortical thickness, decreased white matter maturation, and decreased volume of the amygdala, hippocampus, and so forth. So this is really serious. When we're not assessing pain and we're not preventing pain and we're not treating pain, we're actually leading these children to impaired neurological development for life. But it's challenging. We don't have a universally adopted assessment tool because all the tools we have been developed for specific populations and settings. But what is recommended is that we in our unit decide on which assessment tool we are going to use and when we're going to use it, how often we're going to repeat it, and that we train all our providers. None of these assessment tools are perfect, and we must take into account that our patients might have altered responses because of prematurity or neurological impairments, or maybe because they're paralyzed. And these are a few of the pain scores that are out there. Only a few have been specifically modified or made for the preterm infant, like the PPIPR1 or the NIPS, but they can all be used from birth on in preterm and term infants, and they all have their pros and their cons. Most of these are based on factors like behavior, gestational age, and physiological parameters. But we don't really know what's really going on in the cortex and what the physiological responses are. So probably in the future, we need to use a more multimodal evaluation. And the question would be, which method should we use as reference? Today, all the other ways, except for the pain assessment tools, have mostly been used in research. So our neonates undergo multiple procedures daily, and these are the French data. These were 14 centers with around 1,400 newborns, preterm infants, 14 days of hospitalization. The median number of procedures, they could be routine care, like suctioning, or that we remove the plaster or something, or just taking a blood pressure. But these were assessed as being painful using pain scores. The median was 10 procedures per day. The maximum was 50 procedures per day. You can see that none of these were doing something like surgery or inserting catheters. And 80% of these children did not have any analgesia specifically for this, and 45% did not. So we can say that even for what we estimate to be just daily routine procedures, they are a sort of stress and of pain to the infants. So what can we do? Well, first of all, we need to assess correctly, because assessment is essential to safe and effective pain management. We have the responsibility to do this. And we have to choose an adapted strategy, adapted to our patient population, to our provider population, to our resources, and to our training. And we have to train everyone to use it. We have to decide that pain is the fifth vital sign. We have to decide that pain is a priority. And this is, even ethically speaking, our responsibility. We have to have written guidelines and protocols. And what we can do is to make the care environment, let's say, what we can do best to make it adapted to newborn well-being. For example, family-centered care, if we can. We can program the stimuli to when the parents are there. And of course, avoid unnecessary stimuli, regroup them, not do them all through the day, and reduce painful and stressful procedures. And we can use the tiered approach, for example, baseline, where we're avoiding, we're trying to minimize, and we can use non-pharmacological methods for a majority of things we do. For example, breastfeeding or non-nutrient oral sucrose, non-nutritive sucking have been shown to effectively reduce pain and discomfort from routine care measures and minor procedures. There's a high level of evidence. And we can do multiple things together. I mean, we can do facilitated tucking, we can do sensory saturations. It could be that we're rocking the baby, we're tucking it, we're giving it oral sugar, and they all are very effective in reducing pain and discomfort and preventing that pain goes out of hands. And if this is not enough, and if we have more procedures that are, let's say, more invasive procedures, like if we're putting in a line, if we're preparing for more invasive things like a chest drain or so forth, we need to step up our arsenal. We need to know the side effects. We have many drugs that we can use, but of course, no drug is without its side effects. So we need to know specifically what potential side effect we can have for our patients. For example, opioids, they are very good for pain relief. However, side effect could be that they will depress respiratory drive. So we need to titrate and we need to use adapted dosage. Paracetamol will reduce opioids, but is not very good for procedural pain, and so forth. I think we have a long way to go in order to find the best drug for the best situation. And again, we might need to titrate doses according to response, and this is a lot of work ongoing on this. So what can we do? We can start off by saying that this is our priority, that this is something we have to include in our evaluation methods, and we need to choose which pain evaluation we're going to use, train our team, and decide how often we're going to assess and reassess, and then set up a strategy how we could prevent the painful stimuli, how we can prevent pain from painful stimuli, and when we need to step up and use pharmacological methods, then which ones, how long, and how are we going to evaluate whether they're working or not. So in conclusion, unfortunately today, worldwide, pain and discomfort are so common in the NICU. But we do know that prevention and treatment leads to improved outcomes, and this is what we want. We want improved short-term and long-term outcomes. Inadequate pain control may lead to serious long-term adverse effects. We need to be able to assess, and this is a challenge because it's not easy to communicate with a newborn. But we do have available methods that we can use, and today we're largely underusing them. And in the end, we have to work together as an institution, as a team. For each institution, there has to be an adapted approach to pain prevention and adequate pain relief. And this, in my opinion, should be a priority. So I'd be very happy to take your question after the break, and thank you very much.